encourage having the berries, the spinach, and all of those things. Yeah, definitely. It's the variety from the food diet, right?
If one had an iron deficiency, what would be the most obvious symptom?
Fatigue, no energy, and that's from my experience. And from my experience with people that I see, the deficiency happens so slowly that with the fatigue, they just think it's normal. It's just a normal part of just being busy or whatever, but they don't realize once they have this supplementation or get treated for it, or like their life is, like you had said, you can run a marathon or whatever, because it does have a major impact on your quality of life. But it just goes down so slowly that you really don't know what normal is. Right? Is that, yeah.
Thank you.
Yeah, yes.
Hi, sorry, one more question. In regards to supplements, I have iron deficiency, so right now I'm taking a liquid supplement that I found because it's not quite as hard on my stomach as some of the ones that I've gotten at the drugstore. So this one I have is from a natural food store. I don't know if it's any better or worse than anything else. Do you have any comments on supplements and one?
Well, Dr. Fardy, that's his expertise. Yeah, yeah, I know like the gut grief is one major problem, and I know there are some newer supplements. Would you like to answer that question?
You're going to talk about that? Yeah, so
Oh, okay.
Dr. Costello.
Yes, yeah, yeah. Okay, so, anything else?
Just I was noticing the heme iron sources that you
Yes.
listed. There seemed to be a big difference between pork liver versus beef liver.
Okay, yeah.
I don't. Is there? I'm
Let's
wondering
see.
why that is.
Yeah.
Pork is so much more.
Yeah.
Whereas cooked beef is 4.9.
Yeah, I really don't know. No, I really don't know why that would be. Yeah.
One of my colleagues who did research told me, and I tell everybody, that moose and caribou have 6 times the amount of iron that beef has. Is that-
Oh.
Yeah, yeah.
Yeah.
Now moose, yeah, is, well, we never did are you looking at the moose liver?
No, just,
Okay.
that was from Dr. Robotham, you know.
Yes,
community
Brad
medicine,
Robotham,
and
yeah.
Some of the people who work with
Okay,
her.
yeah.
So I don't know where the reference is, but
Yeah.
I've been telling people that. I think I've got it right.
But now on this table, like moose meat would be basically 2.5 to 3.8. Yeah, so I don't know. Yeah, it could be, yeah, I don't know.
Because I never realized there's a difference.
Yeah,
That much of a difference.
yes, yeah,
Same organ.
yeah, definitely. Yes.
Just a quick question. Anyone who's a diabetic and they're taking insulin daily,
Yes.
does that have an effect on your iron levels?
I don't think would, no, not that I know of, no. Yeah, yes.
Would you mind commenting on cooking with iron concentrates?
Yes, I was
That
mentioning.
It is supposedly would increase the amount of iron in the food. Yes, I know, I can remember my grandmother's iron frying pan and it was really black and yeah, so it would definitely, unfortunately I don't have the latest research or whatever with regards how much, but it would certainly help, definitely, yeah.
So no more questions. We're going to have a panel discussion at the end. After our panel discussion, we have more questions for Kelley at 20 minutes.
Oh, no, they're my notes. Unless you took on this.
Well, thank you, Kelley, so much.
Thank you.
So next I'd like to invite Dr. Jacqueline Costello to come up. So presentation. So Dr. Costello did her medical training at Memorial, followed by a fellowship in hematology at Dalhousie University. She's currently a hematologist at Eastern Health since January 2014. And I'll let her introduce her discussion for today.
Thank you, Eric.
No problem.
So I'm really glad to be talking about iron today. Iron's sort of my friend and my foe. I'm just starting my medical career, so I'm sort of having an interest in iron overload. So that's sort of my friend, because I deal with a lot of bone marrow problems. And iron deficiency I like to think as my foe. I just wondered, how many primary care physicians, is there any family doctors? One. But not from the community, okay. I wasn't quite sure what the target audience would be, so I had hoped there would be some primary care physicians so I could sort of talk about the problems with the delivery of consultations and things, but I'm glad that all you guys are here this evening. So, if most of you aren't familiar with UpToDate, UpToDate is a sort of a physician searchable engine where we can come up with a lot of useful medical information. So UpToDate, which I sort of use as my crutch when I was a medicine resident, cites that actually a quarter of the world are anemic, with about half of those resulting from iron deficiency. But they didn't give me references, so I was a bit skeptical about that. But from the CDC, from SEER data, where they can actually look back through databases, they say about 10% of Americans, which is translatable to Canada, live with anemia. And about half of that, or 5%, is related to iron deficiency. And in our hematology department, we receive at least 5 consultations a week for either iron deficiency or iron deficiency anemia. And we only receive about 30 to 50 a week. So that's about an eighth or 1/7 of all the consults that we receive are from iron deficiency. So why do we need iron? Well, now after the dietitian's talk, I feel kind of foolish putting Popeye up here, because apparently he's not getting a great source of iron. He has to put some loose liver in his can. So why do we need iron? So iron is essential for making red blood cells, and that's why people feel tired, because there's less red blood cells to carry the oxygen around. And myoglobin is an integral part of muscles. So that's why when you're iron deficient, you can feel sort of achy and tired in the muscle. So we're going to get a little bit sciencey in the next couple of slides, but all of our enzymes in our body which transfer energy are all dependent on iron as well. So those two enzymes there, cytochromes and reductases, are actually the two most common sort of enzymes for transferring energy. And neutrophil activation, so neutrophils are the white blood cells that fight bacteria, so they need iron to let out a neutrophil burst, which is probably a reason why patients with iron deficiency are not only tired, but also sort of pick up colds and things like that. So here's the heme molecule. So here's your red blood cell, and all throughout are these heme molecules. And right smack dab in the middle is the iron molecule. So this is why iron is such an integral part of the red blood cell. So how do we absorb iron? So like we heard, we should get somewhere between 10 to 20 milligrams of iron. And our gut is actually programmed to only absorb 1 to 2 milligrams of that a day. And between that and the liver, there's a lot of enzymes and hormones that actually stop you from absorbing more, so that you don't get into trouble with iron overload in the liver or the heart and things like that, because there's actually no physiological mechanism to excrete iron, and that's the problem sometimes with IV iron. So iron gets absorbed through the gut, gets transported all around us from a protein called transferrin. And then what transferrin does is it ships about 3/4 of our iron to our bone marrow to make red blood cells. About 10 to 20% should be stored as ferritin, which I'll talk about in the next couple of slides. And 10 to 15% is used for other processes like those enzymes and energy transfer, things like that. So what do we find in the lab? So sorry for all these acronyms. So the CDC is called the complete blood count. And that's how we know when your hemoglobin is low or your white count is low or high. So I'll stick to the important things. So your platelets can go up if you're iron deficient. The size of your red blood cells will get small if you're iron deficient, and they'll look pale. And I'll show you some pictures of that in the next couple of slides. Reticulocytes are baby red blood cells, so they're how your bone marrow pushes out blood cells. And they are decreased when you have iron deficiency because you don't have the building blocks to make those red blood cells. So we sort of alluded to the fact that ferritin is the test that we look for to see if your iron is low. There's a lot of other tests that we can look that are really not quite as important as ferritin. There's one that I really like, and that's why I hope there be some family doctors here, called the transferrin receptor, because ferritin is actually an acute phase reactant. So you could be iron deficient and have actually a normal, according to Eastern Health's lab, iron level, because you could have rheumatoid arthritis or some sort of inflammatory process. So I use the transferrin receptor to sort out what's actually iron deficiency versus someone who has a lot of inflammatory problems. But that is a send-out test, and I do it very rarely. It's for people who have high suspicion of iron deficiency. So this is a normal blood film. For most, I guess most people in the room haven't seen a blood film, but this is a lymphocyte. So those are the little guys that fight viruses. This looks like maybe a monocyte. So this is sort of like a cell that would chew up bacteria, things like that. And these are all of our red blood cells. So these are nice, round, healthy-looking red blood cells. But you can see a stark difference. So this is what we see under the microscope for patients who are iron deficient. So you can see here, they're all sort of close together. Here they're quite sparse because this patient's anemic. And the red blood cells are all pale and white looking. So you can see why you would feel so bad, because you have red blood cells that really aren't working very well. All these little dots all around are platelets, so the platelets are increased in this patient. Again, just showing that the red blood cells are a lot paler and distorted looking compared to that healthy film. All right, so I just sort of wanted to give an overview of how iron's absorbed, what happens. I think Dr. Farag is going to talk more about symptoms. So what can we do? So first of all, we don't want to just say that iron deficiency is physiologic. You want to do a good history and physical to make sure that people are eating enough, but really you want to make sure that there's no source of blood loss. And in our province with huge incidence of colorectal cancer, you really want to rule out malignancy, and I'll let Dr. Farag talk about that. But not only gastrointestinal, which is the sort of #1 cause to lose blood, but you also want to look at other things, so women, endometrial, cervical, bladder cancer, hepatoma. Unfortunately, with a lot of the iron deficiency consults that we see after gastroenterology is seeing them, we'll often find, not often, but we'll find other tumors. So I'll do a CAT scan and patients will have renal cell cancers or lung cancers and things like that. So not to be alarmist, just because you're iron deficient, it doesn't mean that you have cancer, but you certainly want to rule out the most serious things. So we've already talked about the Health Canada recommendation for the normal non-iron deficient person. And I'll go over what the recommended doses for patients with iron deficiency and actual anemia are. So the general principles is that iron is absorbed mostly in the small bowel, and so that's why a lot of these extended release capsules of iron were taken off the market, because they get absorbed sort of lower in the GI tract, so they're not very effective. And the other thing is the most effective tablets, which I'll talk about, are actually the iron salts. And they shouldn't really be given with other foods because those salts combine with iron and impair absorption. And you also want to have a good acidic medium for the iron to be absorbed. We've already sort of talked about this, but it should be given on an empty stomach for patients with iron deficiency. So you should take your iron supplementation 2 hours or 4 hours after the ingestion of antacids, and on an empty stomach is the best time. So I tell patients, put your pill bottle next to your shower, so you take it as soon as you get up, or put it on your nightstand so you take it right before you go to bed. And it's definitely best absorbed in an acidic medium, so we've already talked about vitamin C. The preparations are vastly different in cost, and I'll go over the tablets in a couple of minutes. So you want to pick the preparation for yourself or talk to your doctor what's going to be the most effective with the minimal side effects and the most cost effective. So iron sulfate is definitely the cheapest, costing probably about $5 a month, whereas things like Ferromax, which I'll talk about, are more like $30 a month. So again, the most appropriate iron tablet is something containing a ferrous salt. I'm actually doing a master's course under Dr. Farady's supervision, and I'm actually looking into which iron tablets are the most effective. And there's actually no randomized data to show that any of these iron tablets are the best. Some of the older physicians would definitely say that things like ferrous sulfate are more bioavailable, and you will get a better result from it, but there's no randomized data. So ferrous fumarate is called Palifer, and that contains about 106 milligrams of elemental iron. Ferrous sulfate is the cheapest and sort of the oldest. That contains about 65 milligrams. Ferrous gluconate, 28 to around 40 or so. And Fairmax is the newest kid on the block and is definitely the most expensive. And it does have 150 milligrams of elemental iron per tablet. But again, elemental iron versus bioavailable is sort of a different story. So these are all iron salts. But Fairmax is the sort of most easily tolerated, but is a polysaccharide. And apparently, again, no randomized data, but is not as absorbed as well as things like ferrous sulfate. But you can't really say that one is better than the other, sort of a trial and error. So the recommended daily dose is between 150 to 200 milligrams a day for someone who's iron deficient or anemic. And so you need to do a combination, obviously. I think I have it on the next slide. No, I don't. So if you're going to take ferrous sulfate, you're going to need to take about 3 tablets, whereas Fairmax, you can take 1. Ferrous gluconate's the same. You may need to take 2 tablets 3 times a day, whereas something like Palafor, you could probably get away with just 1 tablet a day. So side effects. So has anyone taken oral iron? I have. And I know it's pretty nasty sometimes to take, so it's definitely a trial and error. And it can result in a lot of GI upset. So nausea, constipation, dyspepsia or epigastric distress. Very rarely vomiting, but some people can get pretty nauseated. So what you can do is switch to a smaller dose of the elemental iron, so things like ferrous sulfate with a smaller amount, or switch to the elixir, which you had mentioned earlier. So what I tell patients to do is, if they're really iron deficient, I do want to get their iron up as quickly as possible, but I also want them to be able to be compliant and take it. So what I'll often do is, I'm going to give them ferrous sulfate, and they're going to need to take 3 tablets a day. I say, take 1 tablet a day for a week, then 2 tablets a day for a week, and gradually go up like that. Do not take tablet with meals because it will decrease the absorption. So if you're anemic, I think that you should continue on for several months, but what I send a note back to their family doctor to recheck all the blood work in 6 weeks. So repeat the ferret and the CBC. And again, there's no good, we're coming up with some guidelines which will hopefully direct a lot of primary care physicians. But some people stop it when their hemoglobin is normal, but if there's a non-reversible cause, I say that they should continue on at least 6 months and really go from there. So what if you were really good and you're taking your iron every day, which is often, I have to admit, the problem with patients is they're not compliant because they're having so many side effects. What do you do then? So you're taking iron for 6 weeks and there's no increase in your iron. So either you're looking at an incorrect diagnosis, so you don't actually have iron deficiency, or there could be a coexisting disease that's causing you not to absorb iron. Maybe you have Crohn's, maybe you have celiac. Non-compliance is definitely one of the biggest things with the patients that I've seen. Difficulty with absorption, so are you taking Perry twice a day or some stomach pill that's decreasing the acid? Or is the iron loss bigger than the amount ingested? So if you have von Willebrand's or some disease where you're bleeding, you're really going to need to step up your iron. Or again, if you have iron malabsorption like celiac or H. pylori. So I just want to put this in there. There's a huge table there and up to date that says, the reasons to cause failure for iron oral replacement. So they're quite firm and vast. So don't feel bad about yourself if you're taking the iron and you're not getting the result that you want. So IM iron we don't recommend at all. Used to be used years ago before the IV iron came about, and don't recommend it at all. I know some primary care physicians do still use it. I think you're not tolerating orally, we should switch you to IV. So parenteral or IV iron, so the indications are when the patients can't tolerate it. So patients have tried all different forms, they really can't get through it. Or again, if the iron loss exceeds the oral replacement, so you really can't keep on top of it, you have Crohn's or bleeding disorder. Patients on dialysis often get IV iron with their red blood cell boosting medications, and patients who are anemic from their cancer therapy. I've also had patients who are quite anemic, and that's an indication as well. So someone comes to my clinic and their hemoglobin's 80 and they're having palpitations and whizzing in their ears. Well, then I think it's time just to get on with an IV treatment rather than put them through the sort of misery of weeks trying to get back to normal. So I'll kind of skip through a lot of these things. So iron dextran was one of the first forms of IV iron, but there's a lot of side effects, a lot of allergic reaction. So I don't think anybody orders that anymore. Two of the sort of more common ones are ferrogluconate, which is called ferrolicet, or iron sucrose, or vinifer. So those are probably the two most common ones. In order to give these, you actually have to calculate the iron deficit, and so I'm a little bit too lazy for that. So I like this new product called Ferriheme, which is ferromoxidil, which delivers 1 gram of elemental iron in just 2 doses a week apart. So the other ones can be up to 6 to 8 weeks for patients. So I like this because patients just come in twice, get the same dose, and it does have a similar side effect profile. The biggest thing about this one for Eastern Health is you can't have any drug allergy. So if you have any drug allergy listed on your file at all, the ambulatory treatment can't give it. And if you're going to have an MRI within 30 days, you can't take it either because it switches the T2 to T1 weighted images. So those are the options right now at the Eastern Health for IV iron. So I don't think I need to go through this, so that's just how you calculate, how we as physicians calculate the dose of IV iron. So just in the last couple of slides, so oral therapy for iron deficiency, so we need to get about 100 to 200 milligrams of elemental iron. So that's anywhere from 1 to 3 tablets, depending on what formulation we go with. Try to take it on an empty stomach. Duration, at least 6 weeks if you're anemic, then I recheck your CBC and your ferritin, but it could be up to 6 months. Side effects are definitely well reported, and there's ways around that, again, taking it at night, and trying, to slowly increase your dose. For IV iron, the indications really are rare because we do try to avoid it because of the risk of allergic reaction and iron overload for patients who aren't that iron overloaded. So if you have a normal hemoglobin, your ferritin's 40, I'm probably not going to give you IV iron. I'm going to tell you to keep trying the oral tablets. And really just for patients who can absorb iron, one of those other indications, or really, really bad noncompliance, and I want to get their hemoglobin up. So iron deficiency, just in the last slide, is not routinely assessed by hematologists, and unfortunately because of the huge influx of consults, patients often have to wait several months. I know Dr. Scully and I are one of the two that sort of, we see iron deficiency, we try to get it in, but the others are much too busy with things like leukemia, lymphoma. So we try to send back letters to the primary care physician saying, this is how we treat it, and the primary care physicians actually can order IV iron at the ambulatory treatment clinic in St. Clair. So if you have severe iron deficiency and oral tablets aren't working out for you, and you can't wait several months to see a hematologist or a gastroenterologist, you can mention to your family doctor that they can indeed order the IV iron at the ambulatory treatment clinic at St. Clair's. But you also want to make sure compliance with your oral medications first. So you don't want to give up on oral iron right away. And again, make sure that there's no blood loss and no blaring serious reason that could be corrected. And that's it. Now to answer the question about the elixir. So there are some elixirs on the market, but they are all those same tablets that I mentioned. So they're all liquid forms of these salts. So Ferromax actually has a nice elixir right now where it's fruit flavored and you can put it into water and take it as a drink. So it is sort of the same thing that's in the tablet, but I had an 18-year-old who actually took Ferromax, didn't like it, took the fruity drink and tolerated it much better. It is expensive, so Ferromax is about $30 a month and the elixir I think was $45 or $50, but sort of easier tolerated. I think GNC also has a ferrous sulfate that's pretty nasty tasting, but again, for some reason is better tolerated than ferrous sulfate. And I don't have a reason why the elixirs would be any better tolerated unless the tablet is just sort of harder to break down in the stomach, or maybe some extra, fortifiers to keep it as a tablet. But it is the same material as found in the pills and the elixirs. Question?
Yeah, in terms of what can you do to increase absorption, like totally empty stomach, or should take orange juice with it?
Orange juice is good.
So just a glass of orange juice, vitamin C pill, and that?
Exactly. I do honestly tell patients to put it by their shower, take it as soon as you get up, because you're less likely to eat within, at least 30 minutes. For some people to say it's impossible for me to take these because I'm always eating. So probably the biggest space for patients is as soon as they get up or before they go to bed.
Like what's the ratio in terms of like 1 hour before versus 2 hours after kind of thing? Or how do you kind of,
Yeah, so they recommend 2 hours, which
after,
is pretty hard,
before or after?
both.
Okay.
So I think if you can get a good, at least a half hour, Dr. Ferry is an expert in gastric emptying things, but I think if you can get a good half hour with no food in your stomach, you're pretty good.
What's the average, what is the normal iron number? Like I've been 17,
That's a lot.
yeah.
So Eastern Health says 30 to, our reference range is 30 to 50, but there's a lot of, like the World Health Organization would say less than 50, or less than 50, yeah.
I think it's less than 30.
Is it 30?
Yeah. But the 30 to 100 is a grey area because if there's any inflammation, you're actually iron deficient. So one of the issues is that because iron deficiency is so common, if you look at normal ranges, the World Health Organization, it used to be accepted that it was normal for women and small children to have ferritins around 10. So that lower limit has been going up as people have realized that it's actually not normal, it's just very common. So currently the World Health Organization, the lower range is 30, but 30 to 100, as Dr. Costello was saying, because ferritin is the key phase reactant, it's very common, 30 to 100, that people could be iron deficient. And where I work a lot with people with severe bleeding disorders, there's old literature showing that iron is actually important for platelet function as well. And there are old studies showing in women who are having a lot of trouble with their periods that when they were given iron, they had less bleeding. And I certainly see that in my patients who have those problems that often, if I can get their ferritin to 100, everything gets better. Their bleeding gets better. It's like a real vicious cycle. But and also, I like it at 100 in case you do have a bleed or something that you have a bit of a reserve, or if a woman becomes pregnant. So I find 30 is I mean, it's not unhealthy, but I just find 30 is a bit low. And I do have a lot of people, not everybody, but there are a lot of people who really feel better when their ferritin's around 100.
The old reference range was either 10, below 10 or 20. So a lot of family doctors who don't look at the sidebar just have 10 in their head, so they say, no, you're fine. In fact, Central Health still uses 10 as their reference range. Dr. Ed Randall here is trying to swoop everything and change all the reference ranges. So you may have some people who still have 10 or 20 stuck in their head, which is way too low.
Well, I've been on for probably about maybe 3 or 4 months now, I've been on the glutamate, and I've been checked for, all of the things that you talked about, and I don't have heavy periods, and, your regular practitioner, checking for, like the thyroid and all that kind of stuff. I think we probably got it up to maybe 20, and then like a bit 4 months later, and now I'm back down. I'm actually dipped lower than 17. So now she has me on the fumarate, I do believe. So we're trying that. So at what point, without getting into my whole details of my story, but at what point, do I a year let this go on orally, and then like, at what point do I say, okay, well, this is nothing's happening here.
Yeah.
What do we do there? Any advice there?
Yeah, that's a good point. So for IV iron, it's very easy for me. So if I have to give someone IV iron, I give them 1 course. That Max should last a year. So they last less than 3 months with that, and they're not having menorrhagia, and they're eating iron, well, then I send a consult immediately to Dr. Ferry. Because, again, not the reason why iron fails, not necessarily cancer, but maybe you have gastric ulcer, or maybe you have H. pylori, which is a very common bug in Newfoundland. So that's for IV iron. For oral iron, I usually let patients go through 1 therapy for 6 weeks. And if I see absolutely no change, then I'll switch to another therapy, make sure they're maximizing using good compliance. If that doesn't work, then I send, again, a consultation to GI. Now, an 18-year-old girl who's completely asymptomatic, no GI symptoms, no dyspepsia, no heartburn, things like that, I mean, we don't need everybody to be scoped. Dr. Friday's going to talk about that, but certainly there are things that hide in the GI tract, like inflammatory bowel disease, celiac, a lot of really common things. And so usually gastroenterologist would be my first go-to. then if I get a referral from a gastroenterologist, or if a patient's already seen a gastroenterologist, well then we'll look further, like, are you having blood in your urine? Do you need a CAT scan? Do you have family history of anything that would stand out that would cause blood loss?
But I'm just wondering, how long do I consult with my family doctor before I say, okay, can we refer me to, because that seems not be.
I think 3 to 4 months,
Okay.
3 to 4 months of really
Yes.
complying with the treatment
Okay.
is a good effort.
What's the difference of being anemic and being iron deficient, or is it the same thing?
Yeah, so that is a really good question. So iron deficiency just means that your iron is below that reference range. So your ferritin is below 30. Anemia is less than 120 for females and less than 140 for males. So if you're anemic, you're probably going to have a lot more problems physiologically